Hello everyone. So today we'll cover a lot of topics. First of all, we'll discuss anatomy and physiology of esophagus. Then we'll cover esophageal motility, GERD and bad esophagus, hiatal hernia, esophageal structure and rings, esophageal diverticulum, perforation, carcinoma, and esophagectomy. Because it will be a long lecture, so we'll divide it into multiple segments. First, let's really discuss about the anatomy and physiology and few conditions we'll discuss along with it. So what is the length of the adult esophagus? Out of the four options, the answer is option A, 25 centimeter. It is 25 centimeter because we know it, and it has three divisions: cervical esophagus, thoracic esophagus, and abdominal esophagus. Division of this 25 centimeter like this: 5 centimeter, 18 centimeter, and 2 centimeter. Okay, cervical esophagus is 5 centimeter, thoracic esophagus is 18 centimeter, abdominal esophagus is 2 centimeter. So 5 plus 18 plus 2, it becomes 25. See, it starts from the cricoid cartilage. Esophagus starts from the cricoid cartilage and goes up to gastroesophageal junction. It starts from the cricoid cartilage and goes up to GE junction at T10 T11 level, and this one is at C6 level. Another structure which is also 25 centimeter long is duodenum. How duodenum is divided? 5, 7.5, 10. So it's progressively increasing. 5, then 7.5, then 10. कितना हो गया? 5 plus 10, 15. 15 plus 7.5, 22.5. So the last one is 2.5 centimeter. Total 25 centimeter. 5, 7.5, 10, 2.5. First part of esophagus, first part of duodenum, second part of duodenum, third part of duodenum, fourth part of duodenum. This one is called the superior part. First part of duodenum is called the superior part. This one is the descending part. This one is the horizontal part, and this one is again the ascending part. So it is superior, descending, horizontal, and ascending. We call this ascending, this segment of the duodenum, because the horizontal segment of I'll draw this. The ascending part. So the horizontal part, this is the horizontal part of the duodenum. This one is at L3 level, but this one is at L2 level. Okay, that is why we call it this part is called the ascending part. Now coming back to the question, which of the following is not a natural constriction of the esophagus? See, esophagus has the first constriction at the level of cricoid cartilage, second one at the arch of aorta, third one at the level of left main bronchus. So answer is right main bronchus is not a constriction. The last is the hiatus. Okay, bronchus. Hiatus, diaphragmatic hiatus is the last. I'll write it. The hiatus of hernia of diaphragm through which the esophagus enters, that is the fourth constriction. So origin के वहीं पे constriction है cricoid cartilage में at the level of C6, at the level of diaphragmatic hiatus of the esophagus, arch of aorta, and left main bronchus. Okay. So the cervical narrowing is called the upper esophageal sphincter, which is at the C6 level at 15 centimeter distance from the incisors. So the upper esophageal sphincter is located at 15 centimeter distance from the incisors. It is at C6 level. We have the first constriction. The second constriction is by the arch of aorta, which is at T4 level. The next one is by the left main bronchus, which is at the T5, T6 level. So first arch of aorta and then the left main bronchus constricted. Then the esophageal hiatus, the diaphragmatic hiatus at T10 level, and the end of the esophagus is at T11 level. So opening is at T10, end at T11 level. Okay. Now if you see the course of the esophagus, it first goes in the superior mediastinum, and then from there it goes to the inferior mediastinum, into the posterior part of the inferior mediastinum. So the mediastinum, as you see from the sagittal view, this is posterior, this is anterior, this is above, this is below. So above we have the superior mediastinum, this is the superior mediastinum, this is the, and this entire thing is the inferior mediastinum. Inferior mediastinum again divided into anterior, middle, posterior by the heart. The heart, pericardium, ascending aorta, pulmonary trunk, the main outflow tracts coming from the aorta, coming from the heart, ascending aorta and pulmonary trunk, SVC and phrenic nerve, they are part of the middle part of the inferior mediastinum. In the posterior mediastinum we have the esophagus. Now the line which divides the superior and inferior mediastinum is the anteriorly we have the sternal angle called the sternal angle of Lewis, and posteriorly we have the T4 T5 level intervertebral disc level. So angle of Lewis to T4 T5 intervertebral disc level. Okay. Now of these four constrictions, most common site for lodging of foreign body is the first constriction, cricopharyngeus. It is the narrowest part of the esophagus. Okay. Now the sphincters. We have upper esophageal sphincter and lower esophageal sphincter. The upper esophageal sphincter is at the level of C6, that is by the cricopharyngeus muscle. Weakening of this cricopharyngeus muscle is responsible for the Zenker diverticulum. So remember, upper esophageal sphincter, it is C6 level, cricopharyngeus muscle. Lower esophageal sphincter, it is at the level of the gastroesophageal junction, that is the end of the esophagus. We have the lower esophageal sphincter, it is at T10, T11 level. Some books write it at T11 levels. It's a physiological sphincter, but the upper esophageal sphincter is an anatomical sphincter by the cricopharyngeus muscle. So function of the lower esophageal sphincter is to prevent acid reflux. The function of the upper esophageal sphincter is to prevent food and air. So lower esophageal sphincter, its defect leads to GERD, where the tone is much low, so there is acid reflux, and in achalasia the tone is very high, so nothing can pass. So these liquid things cannot pass. In upper esophageal sphincter, it's a striated muscle because the esophagus is divided into three parts: upper, middle and lower. Upper is skeletal muscle, middle is mixed, lower is smooth muscle. Skeletal, mixed and smooth muscle, three layers. In upper esophageal sphincter we have the skeletal muscle, that is the striated muscle. In lower esophageal sphincter we have the smooth muscle. Upper esophageal sphincter is voluntarily controlled because it is controlled by cranial nerve 9 and 10. You can control it, you can itself control it. But lower esophageal sphincter, it is involuntary, it is under the control of vagal nerve mainly, but also by the enteric nervous system. So it's involuntary sphincter. Now in esophagus we have innermost lining of mucosa, then submucosa, then muscularis propria, and then finally adventitia, not serosa. Here serosa is not present because it's an extra, it's a retrobradal organ. Adventitia is just loose connective tissue, but your serosa is connective tissue plus mesothelium. Mesothelium is nothing but a simple squamous epithelium layer. So it is mesothelium plus connective tissue, that is serosa. But adventitia is purely loose connective tissue. Now difference समझ में आएगा अब कहाँ पे कौन होता है. Adventitia is found in the retroperitoneal organs, serosa in the intraperitoneal organs. So what are the retroperitoneal organs? Thoracic esophagus is retroperitoneal, abdominal esophagus is intraperitoneal. So thoracic esophagus will be lined by adventitia, but abdominal esophagus will be lined by serosa. Then esophagus के बाद जो stomach है, that is interperitoneal. So esophagus is extraperitoneal, but stomach is intraperitoneal. Small intestine, that is duodenum, jejunum, ileum. Most of the part of the duodenum is in the intraperitoneal, and transverse colon is intraperitoneal. But thoracic esophagus, ascending and descending colon are retroperitoneal organs. Actually, fourth option will be your duodenum. Duodenum is also a retroperitoneal organ, because if you see the duodenum, it is like this. So only the first 2 centimeter of the superior duodenum is intraperitoneal. That is the part which is in continuation with the stomach, because stomach is intraperitoneal. So the part which is in continuation with the stomach is the intraperitoneal part. It is not even the entire superior intestinum, not even the superior duodenum. Superior duodenum is only 5 centimeter. Only out of 5, only 2 centimeter is intraperitoneal. Remaining 3 centimeter extraperitoneal. 7.5, 10, 2.5. All 3 of them. This one. They are all retroperitoneal, and they are lined by adventitia, not serosa. Ascending colon, descending colon, also adventitia. So it has mucosa, it has submucosa, it has muscularis propria and adventitia. So I was telling you that upper esophageal sphincter is controlled by vagus and glossopharyngeal, and lower esophageal sphincter is under vagal tone and enteric nervous system control. Let us continue to discuss some questions. So the lower esophageal sphincter, it is made of skeletal muscle? No, it is smooth muscle. It is under voluntary control? No, it is under involuntary control. It relaxes during swallowing? No, it does not relax during swallowing. No, it relaxes during swallowing. Sorry, contract पढ़ रहा था मैं. So when you take food, the upper sphincter relaxes as well as the lower also relaxes. The lower esophageal sphincter is composed of smooth muscle, not skeletal muscle, and it is normally contracted at a resting state. So LES is normally in a contracted state. It is normally in a contracted state. So when you are resting, it is in a contracted state, but when you swallow, it will open. Which nerve primarily controls the esophageal peristalsis? It is vagus nerve. Vagus nerve is the main controller of peristalsis. Also the lower esophageal sphincter too. The basal LES pressure, the basal lower esophageal sphincter pressure, is maintained primarily by the smooth muscle. Okay, the myogenic tone of the smooth muscle, but also there is role of the hormones and neurotransmitter in this. So normal LES tone is between 10 to 45 millimeter of mercury. Okay. Now, what are the factors which increases the lower esophageal sphincter tone? Hormones like gastrin and motilin, because they are trying to propel the food downwards, so they will increase the tone. Anything that wants to push food from the esophagus to stomach, from stomach to duodenum, they will increase the ileus tone so that food does not go back to the esophagus. So gastrin, motilin, ACH, there is acetylcholine vagus. Then drugs like metoclopramide, domperidone. So how these drugs increases GI motility? Let me write. Okay. How these drugs increases GI motility? See, dopamine is anti to acetylcholine. So acetylcholine increases peristalsis. Dopamine, what it does, it inhibits acetylcholine release from enteric nervous system. Dopamine inhibits the release of acetylcholine from enteric nervous system. How metoclopramide works? I'll write in short metoclopramide. How it works? It blocks the D2 receptor. डोपामिन के जो रिसेप्टर्स हैं D2 रिसेप्टर्स, उनको ये क्या करता है? इट ब्लॉक्स दी D2 receptor. Metoclopramide blocks D2 receptors. By blocking D2 receptors, see dopamine, how it works. Dopamine comes and binds with the neurons of enteric nervous system and tells them to stop the release of ACH by interacting with D2 receptor. If I block this D2 receptor, dopamine will not be able to bind, so ACH production will increase and peristalsis will increase. Second mechanism of metoclopramide is it works on the 5-HT4 receptors. So these are serotonin receptors. There are many types: 5-HT1, 2, 3, 4. These are the most important ones. 5-HT4 receptor. What it does is it stimulates the 5-HT4 receptor. Stimulate and block D2 receptors. 5-HT4 receptors. So dopamine is there, again 5-HT is there. So 5-HT, when it comes and binds to the receptor present on the anus called 5-HT4 receptors. When 5-HT binds to this 5-HT4 receptors, it promotes release of ACH. So by stimulating this receptor, metoclopramide also increases the release of ACH and peristalsis. On the other hand, domperidone, क्या लिख रहा हूँ? Domperidone, it only inhibits D2 receptor. Like metoclopramide, it does not have the 5-HT4 receptor agonism effect. So we are clear how metoclopramide and domperidone works by in the peristalsis of in the peristalsis, how these two drugs work and how they help in increasing the ileus tone. Coming back, Okay. Now factors which decreases the LES tone. Progesterone and secretin, CCK, glucagon. See, with these three hormones are produced from the mainly by the duodenum. They are mainly produced by the duodenum. Glucagon is actually mainly produced by the pancreas, but secretin, CCK, they are produced by the duodenum. So glucagon coming from the pancreas, the islets of Langerhans. Which cell produces glucagon? Tell me the answer. It is alpha cell. Alpha cell produces glucagon. Beta cell produces insulin. Delta cell produces somatostatin. I'll just write in short. Alpha cell produces glucagon. Beta cell produces insulin. Delta cell produces somatostatin. Epsilon cells produces ghrelin. There is another source of ghrelin, I'll tell you just in short. So alpha cells for glucagon, beta cells for insulin, delta for somatostatin, epsilon cells for ghrelin, and PP cells, very simple cells. PP stands for pancreatic polypeptide, also known as F cell. So these are the important cells: alpha, beta, delta, PP, and epsilon. Alpha cell produces glucagon, beta cell produces insulin, delta cell produces somatostatin, epsilon cells produces ghrelin, and F cells produces pancreatic polypeptide. Ghrelin has two sources. Okay, one source is the stomach, other source is the pancreas. Pancreas में islet of Langerhans, the epsilon cells produces ghrelin, and in the stomach it is P by D1 cell of stomach. Mainly the cells are present in the fundus region of stomach that produces ghrelin. Ghrelin is produced when your stomach is empty. Anyway, coming back. So glucagon was produced by pancreas. Secretin and CCK, they are produced by duodenum. Which cell produces secretin in the duodenum? S cell. S cell produces secretin. What is the function of secretin? Function of secretin is to act on the pancreas. This will go act on the pancreas and will tell the pancreas to produce more bicarbonate. And cholecystokinin is produced by eye cells. So eye cells of duodenum will produce cholecystokinin. Cholecystokinin will go and tell the gallbladder to contract so that it releases bile into the duodenum. Remember the cell name for secretin, very easy. Remember the cell name for CCK, cholecystokinin, it is eye cell. These hormones will decrease the LES tone, okay, because the person is now taking food. That is why it is producing secretin, CCK, glucagon. Then fatty meal, chocolate, alcohol, caffeine, anything that you take like a fatty meal, chocolate, alcohol, caffeine, it will decrease the LES tone, and as a result you will have reflux. Smoking, obesity, your LES tone decreases, you have increased risk of reflux. Progesterone during pregnancy, again reflux. So in GERD, that is in reflux, your LES tone is decreased. In achalasia cardia, the LES tone is extremely high, that is why nothing is coming down. In diffuse esophageal spasm, the LES tone is normal to increased, but it is mainly the esophageal contraction that is happening, not the LES contraction. It is not the LES contraction, it is mainly the esophageal contraction. So diffuse esophageal spasm में भी थोड़ा बहुत increase हो सकता है. Some amount of increase in the LES tone may be seen with DS. And in scleroderma, LES tone is decreased. Why? Why like GERD, in scleroderma the LES tone is decreased? See, in scleroderma two things happen. First, it is destroying the smooth muscle cells. So the smooth muscle cell is lost and it is atrophied. The smooth muscle is atrophied and it is replaced by fibrosis. See, distal 2/3 of the esophagus is smooth muscle cell and middle 1/3 is obviously mixed. So it is loss of the smooth muscle cells. When you lose the smooth muscle cells and it is replaced by fibrosis, what happens? The LES muscle tone decreases. Similarly, the achalasia cardia also destroys the scleroderma. Scleroderma also destroys the enteric nervous system neurons. If the neurons are destroyed, there is no ACH release, and no ACH release means loss of sphincter tone. Okay, so in scleroderma, because of the loss of the muscle, there is decrease on the LES tone. Remember this, very easy. So what is the finding of scleroderma, which is the systemic sclerosis? In barium study, you will find lead pipe esophagus. So lead pipe esophagus, scleroderma. But can this happen in another condition? Yes, in the end stage of achalasia cardia. But achalasia cardiaca, what is the main radiological finding? Bird beak appearance. So achalasia cardia, the main finding is bird beak appearance, and in scleroderma it is lead pipe appearance. And also along with bird beak appearance, you will find the dilated esophagus having a fluid level with minimal to no peristalsis. So when you see the barium esophagus of a patient with achalasia, the esophagus is dilated, there is a fluid level. You see during fluoroscopy, you see there is no peristalsis going on, or there is very minimal peristalsis, and there is a bird beak appearance. Okay. Okay. Right.